Right. Hello, everybody, and welcome to ACEP Now cast. I'm Cedric Dark, the medical editor-in-chief of ACEP Now. With me today, it's my pleasure to have Dr. Gillian Schmitz, our new ACEP president. And we're going to ask a bunch of questions, some of which have been fielded from ACEP members and emergency physicians around the country, and some of which I came up on my own. But let's start with the hardest question of all. How's the job going so far?
Thank you, Cedric, for having me. It has been a very busy couple weeks. I feel like it's been going nonstop, but we just got back from Boston, and it was very invigorating and exciting to be able to see everybody in person again. So I'm hitting the ground running and really excited to get started.
All right. Well, I remember seeing you in Boston in the elevator, like at the end of an extremely long day. And, I was wondering, how do you handle things like work-life balance, especially considering the fact that we, the ACEP members in the emergency medicine family, have asked so much of you over the past decade of your life?
That's a great question. And I think that work-life balance is so important for all emergency physicians, particularly in this time. So I'm a runner, and I'm also a tennis player. I find it's those hobbies kind of keep me where my mind can go outside of work, and that kind of keeps me grounded. But I think really the support system I have within our community of emergency physicians, and most notably my family and kids, just having that time to kind of unwind after work and kind of get lost in something else, whether it's a TV show or a book or just spending time with friends and family, that's definitely given me time to kind of absorb it all and keep myself kind of grounded and level.
Excellent. Well, you told us a little bit about yourself, but what's something else that the average ACEP member might not know about you personally to help them understand you a little bit more, especially as you are as a leader leading the college?
Sure. So something you might not know about me, I met my husband in medical school. We actually sat next to each other during orientation at a White Sox game. But he had a military career ahead of time, so he had 20 years of service. So because of his career, we've lived and practiced all over the country. And so my career has been really all over the place. I've done a lot of academic practice, but I've worked in some rural emergency departments. I started my own small Democratic group. I've worked in a freestanding emergency department. And I think it's given me a lot of perspective of how different our practices can be and different resource environments that we practice in. But at the end of the day, despite that we have different interests, different politics, different employers, that we are all emergency physicians and we have similar goals. And I think for my leadership style, it's going to be about unity and kind of bringing together the different communities, our different leadership styles, our different practice styles, to really advocate for all of us and for the specialty in general.
That's a great question to segue into this next little segment that I wanted to talk about, where we focus a little bit on sort of what's ahead for ACEP. And I remember I was at the ACEP Council in Boston. One of the biggest challenges you mentioned for the college is reconciling the differences that we have within our own house. And historically we've had differences in issues on a lot of things. And in your opinion, what is it that's currently dividing us, and how do you intend to bridge that divide coming from all these different perspectives that you have actually had the benefit of seeing?
So I think there's a couple things that have really divided us as a specialty and really even as a country. Unlike other specialties that lean one way or the other politically, emergency medicine is right down the middle. We are 50% Republican, 50% Democratic. And although we try to stick to medicine, a lot of what we do in emergency medicine has to do with public health. And there are gray areas, and every year it's something, whether it's firearm safety or climate change or the Texas abortion law, that half of the college wants us to take one action to be vocal. The other half has a very different opinion, and you can be very alienating of half of your membership no matter what you say or do. And so I think our strategy has really been that this is not the Republican College of Emergency Physicians or the Democratic College. We are the American College of Emergency Physicians, and trying to really stick to the patient, right? And really what was within emergency medicine to bring us together to where we can find kind of common goals. The second issue, I think, relates more to our practice style and the changing environment that we're seeing in the workplace of sort of increasing consolidation across all of healthcare that we've seen over really the last 2 decades, but has been escalating at an increasing pace. And I think that's given people a lot of concern and fear and anxiety about our future, and wanting to understand what the impact of the growing corporatization of medicine has. And that's caused a lot of, I think, divisiveness within our specialty over who made this happen? How is this going to affect my future? What is the job market going to be? And I think there are a lot of really important questions that we have to delve into. And there's a lot that we frankly don't know or don't have great data on, but we have anecdotal experience. And I think it's important to acknowledge that the people are hurting right now, and that people are scared, and people are tired, and they are feeling progressively that they have less control over their practice. But I'm seeing that in all different types of employment models, whether it's large corporate groups, whether it's small democratic groups, whether it's academics. And that's really being driven by reimbursement, right? And how emergency care is being funded. That fundamentally affects all of us. So I think addressing those issues head on, I think, is going to be the important part of this. I think, like anything, it's about trust, and how do we regain that trust within our membership? And I think that starts with good communication and good transparency. And so that's where I'm helping to try to bridge those gaps, is to address these concerns head on and not sidestep them, but to really ask the important questions and try to find answers that help all of emergency medicine.
Well, let's try to get into that a little bit. I know that ACEP right now is undergoing a look at a strategic plan for the next several years. What are a few things that you think ACEP will be doing over the next 2 to 3 that might transform the organization and transform the specialty?
So I think a lot of my residents now, almost take for granted that ACEP didn't exist until just a little over 50 years ago. And so when ACEP started, it was really about defining what the specialty was. It was protecting really the creation of the specialty. And the focus was very much on the entire house of emergency medicine and the specialty itself. Now, 50 years into our practice, our goals are a little bit different. We are now a well-established specialty. We've become one of the most popular specialties for emergency medical students that what they want to go into. But we need to focus a little bit more, I think, on the individual emergency physician. And that, to me, is what I'm hearing from members, is that we went into training to help patients, absolutely, hands down. But we join ACEP because we want someone to fight for us, to represent us and our needs. And I think that is where our strategic pivot is going to be really over the next 2 to 3 years, is how do we best advocate for the emergency physician? And I think the way we do that, again, is really making things more transparent about what we're doing and how we communicate better the things that we are doing on behalf of the individual emergency physician.
You talked about the next couple of years for the college. And one of the other things that I think is really huge that we almost glossed over just then is COVID-19, right? It's this huge thing that we're now so used to as part of our practice. Looking into that landscape, the pandemic hopefully coming to an end, what do you think the value proposition is for ACEP, particularly over the next year during the course of your presidency?
So a couple things. I think the pandemic, the last 18, 20 months have been incredibly difficult on all of us as frontline providers, but many people felt isolated. We're certainly recognizing the impact of mental health on physicians and on our practice. So I think the value proposition is several different things. One is really the sense of community that we have within ACEP, within the emergency medicine specialty. It was really, for me, an opportunity to recharge my batteries of just being around like-minded individuals that I really felt that sense of home, of coming together with my colleagues. So I think that is one value membership. The second is the numerous amount of resources and tools that ACEP has for our members. So specifically to COVID, within 8 days, we have a now nationally recognized COVID field guide that had the most up-to-date kind of how are we impacting this pandemic? How do we take care of patients? How do we protect one another? But beyond COVID, there are so many different resources on how to advance your career, how to get promoted, those leadership opportunities, the publications, the national committees, those are all things that help me advance my career that I wouldn't have been able to do by myself as an individual. But those opportunities that ACEP offered me really helped, launch my career early on. And the third thing I think is advocacy. And this is what ACEP does better than anybody else. But many emergency physicians don't really even understand what advocacy is. But there's a saying that, if you're not at the table, you're on the menu. And a lot of what ACEP does is prevents bad things from happening. And that's a hard sell because many people don't even see those bad things come to fruition because we had an active role in preventing them. But when we talk about how this impacts our individual practice, it's little things like how many of us use ketamine in our emergency departments for procedural sedation. Like, you're welcome. ACEP helped make that happen. Clarifying with Jaco that you can actually eat at your workstation and you can drink water at your workstation. Those are the things that ACEP behind the scenes is doing. But most importantly, right now, it's about reimbursement. And I think COVID really hit home that we cannot be dependent on patient volumes to sustain the healthcare safety net. And when we saw this, 40% decrease across the country in ED visits and hospitals were threatened with having to close their door, this is the value of what ACEP does, is changing the narrative of, do we have to pay for emergency care based on preparedness, the ability to be there 24/7, 365. ACEP is the only one that has a seat at the RUC, to really influence the value of our RVUs and the work that we do cognitively in the emergency department. So that advocacy work is incredibly important. And I think the value proposition is knowing that that's not everybody's cup of tea, right? Not everyone's going to want to go to DC and advocate on the Hill or meet with their legislator. But if you're not, bad things happen to us and to our practice. And so if you're not engaged or involved, support those of us that do carry that flag and fight for us and for our specialty.
I think you bring up a very good point there. ACEP is kind of like public health, and I think people can finally appreciate that in the time of COVID, that most of what public health does is behind the scenes. It doesn't get a lot of attention until something is starting to go wrong. And a lot of what ACEP does, like you said, is behind the scenes. And thank you very much personally for making sure that we can eat and drink at the workstations, because I really hate having to sit there, dying of thirst and going into acute kidney injury just because I'm working my job. So thanks so much for that.
Absolutely.
All right, one thing I wanted to get into, and you mentioned this before, but there's some big issues that I think a lot of members are really concerned about, one of which is what happens with corporate medicine. So I've heard a lot of murmurings from a lot of emergency physicians and ACEP members about how our profession may have sold out to corporate entities. So what do you think the college's role is in the management of our practices, and how do you think the average emergency doc can regain control of their livelihoods?
So I think that's a great question. And I think there has been this perception that ACEP is afraid to talk about it, or that we're in bed with CMGs. And so I think this is really going to be the focal point of my presidency of, let's start talking about it, but let's talk about it with data and truth, and not really by these innuendos and emotionally charged rhetoric that isn't necessarily accurate. Because just like people spread rumors about the vaccine and ivermectin, we need to be able to have open discussions that are respectful and look at these issues that have been very divisive within our specialty. And I think if we look historically, when I graduated from residency, I had a choice of where I practiced and the practice model that I went into. Nowadays, my residents don't have that choice. We've seen such consolidation across the market, across the entire healthcare industry. Hospitals are now health systems, insurance companies, where there used to be dozens and dozens of them. Now, for all intents and purposes, there's 3 or 4, and in many markets there may only be 1. We're seeing physicians are more likely to be employed by either an employer or physician staffing group than they are to own their own practice. And because of that, we've become increasingly divorced how we're reimbursed. And so my perception is that most emergency physicians have a very negative view of the corporatization of emergency medicine. And I think we have to acknowledge that. I think we have to listen to that. But I think what's important for our members to understand is that the corporatization of medicine is not just large corporate groups. This is happening in academic practices. It's happening in small democratic groups. It's happening in the military, where we have people in the C-suite, administrators, nurse officers telling us how to do our jobs. And that's incredibly frustrating to feel that you have lost control over your practice. And that is what I think is fundamentally at the root to this, is how do we empower physicians to have that ability to control their practice? And so I think having more transparency of understanding how things work, to have a voice, really the governance of the group, whether you work in a small group, whether you work in a big group, whether you work at the military, of who is dictating how the department is staffed, how it's run, how do we empower physicians to have more control over their practice environment in any practice model. I think that's going to be really the key to that. And I think where I see kind of that change in understanding is how this consolidation occurred. And fundamentally, it comes from the fact of how healthcare is reimbursed. And because you have less and less insurers there are pros and cons of having a bigger group. When I started my own small Democratic group, I could barely get the insurance companies to return my phone calls, right? They had no interest in negotiating with me because I only had a couple of contracts and I was just the emergency department. If you have 150 contracts, they have to kind of listen to you. You have a little bit more leverage. So there are some pros to having that control or ability to negotiate with the insurers. The downside, people say, well, is that money being passed on to physicians, or is it going into the pocket of, the shareholders, or where is that going? So I think people have to understand what they're getting into and how this model evolved. And part of it, is private equity's investment in all of healthcare, whether it's the CT scanner in your department or the physician group or the CVS pharmacy down the street. Private equity is involved in everything that we do, including investing in many academic groups. But this consolidation has been driven by the fact that reimbursement for emergency care continues to go down and down and down. And now we're being reimbursed based on value. So it's not how many tests you order, it is what is ultimately the outcome of the patients. How do you drive higher quality at lower costs? And so to do that, the only way that groups could survive was cutting their costs or having bigger economies of scale. So these are market forces that have been impacting us, for several decades now, and we're seeing an increase of that because of the reimbursement challenges that we're facing as a specialty. Unlike any other specialty, 2/3 of the patients that we see across the country don't pay the cost of care. And the analogy I make to my residents, is that if you owned a McDonald's and someone said you just have to give out free hamburgers, well, how would you do that if you're not compensated by the government? You'd have to charge really expensive milkshakes, right, to help offset that cost. But the reality is many of the insurance companies, they don't want to pay for chocolate milkshakes anymore. And they're coming up with different kind of ways to sidestep those responsibilities, to downcode or deny various claims. And so it's making it very difficult for small Democratic groups that only have a couple contracts and are only in emergency medicine to remain viable in this reimbursement model. And so that is driving a lot of the consolidation across the entire healthcare system that we need to be able to address. How is this consolidation fueling quality of care? How is it driving cost of care? How is it impacting physician autonomy? And a lot of that we don't have good data on yet. There's a lot of anecdotal stories. There's a lot of people who think they know, but if you look at the actual objective data, there's very little objective data because there's no transparency. And when MedPAC tried to look at this, or when the AMA tried to look at this, or when ACEP tried to look at this, we just don't have good data to really drill down to those issues yet. But we're going to continue to try to get that information to help answer these important questions for our specialty and our future.
All right, well, thank you very much. One of the things you're talking so much about is reimbursement. And you talked about sort of the cost of care. This dovetails with another issue, quite frankly, and one of that is the role of nurse practitioners and physician assistants in emergency care, because, again, one of the largest cost drivers, especially for corporate medicine, is the cost of the intellectual labor that we provide. And it's cheaper to staff with nurse practitioners and physician assistants. So we recently discussed this issue on the workforce panel. If you haven't had a chance to watch that panel, please go ahead and look at it on the ACEP Now website. We have that available. What do you think the leadership of ACEP is doing in regards to the role of non-physicians in emergency medicine? And one particular question that I really want you to get into is this. What do you think physicians should be doing in terms of being forced to supervise an APP that they might deem subpar?
It's a great question. So I think ACEP has always advocated for emergency physician-led care. We are vehemently fighting against independent practice, and it's been very concerning, particularly in the midst of COVID, the amount of state laws that have tried to pass legislation on independent practice of non-physician providers. So ACEP has been very involved. Many of us got to testify at our state congresses to overturn harmful legislation on that. We have won some, we have lost some, and this is going to be, I think, a long haul fight of really advocating the value of emergency physician-led care in the ED. We recently joined the AMA Scope of Practice Partnership to be able to have a bigger voice and utilize their resources. We are creating strike teams to help states that don't have a lobbyist to be able to prepare them and have talking points to speak when these laws are proposed to fight those bills. And we are really working on demonstrating the value to the public of what emergency physician-led care is, and that it's okay to ask, who's taking care of you in the emergency department, and to understand the difference in our training and our qualifications. But the short answer to your question is no, I don't think physicians should be forced to supervise anyone they feel is unsafe. I think we have a responsibility to advocate for our patients. And if we feel that someone is performing poorly, just like I would with a resident or a medical student who is struggling, it's our obligation to our patient to be able to report that. And that underscores, really the need for due process and the ability to have whistleblower protections and to be able to speak to your environment that it's safe and that you're providing the best care for your patients.
That jumps us right into our next question. But before we do, I just want to give everybody a little teaser. We hope to bring you the great story out of the Louisiana chapter of ACEP that did have a fight with scope of practice this last legislative session, and what they did to actually make sure that they were able to prevent nurse practitioners from doing more than they possibly should be doing and practicing independent of physicians in that emergency setting. So let's get back to the issue of due process. It's a big issue for a lot of practicing ER docs out there, and recently ACEP has been fairly vocally supportive of that. The council recently unanimously during our session in Boston accepted an amended version of Council Resolution 31. And I'm going to read that out to you. It says that ACEP is supposed to submit a resolution to the June 2022 AMA House of Delegates annual meeting promoting the concepts of Arizona House Bill 2622 as signed into law as a model state and national legislation to protect emergency physicians from corporate, workplace, and/or employer retaliation when reporting safety, harassment, and fraud concerns at their places of work or government, and which also includes independent and third-party contractors providing patient services at said facilities. And there's a second part to that resolution as well, which says that ACEP should develop this model legislation that emulates Arizona House Bill and share it with chapters through mechanisms like the State Leg and Regulatory Committee. It's a committee I've been on before, and they do a great job of making sure that something that happens in one state gets transmitted to another state so we can learn from one another. So that's the resolution 31 that passed unanimously. Talk to me about due process from the standpoint of the college.
So due process is the ability really for physicians to stand up, and speak out when they feel that there is something going on in the department that shouldn't be. And we adamantly support that. We always have. ACEP has multiple policies on the importance of due process and advocating for that in every practice. We have in prior legislative sessions, and we will be reintroducing this year a piece of legislation with Representative Ruiz on due process and holding third parties accountable that they are not allowed to waive those rights and that this is a fundamental right of every emergency physician. So this is something that is longstanding policy from ACEP, but this is a great way to show how our council works and the democratic process, particularly when something is passed unanimously of we want this, ACEP, fight for this, do this for us, this is what we want to happen. And once we have something pass in one state like Arizona, it gives us kind of that extra fire to fight it in other states and to really develop that model legislation that it has support and that it now has that structure that makes it more likely that it will pass in other states. So I think this is a real win. So whenever we talk about these issues, there's multiple different ways we can approach that issue, one of which is legislative, which we are doing. There may be other legal or regulatory ways that we can explore due process as well. And this is something that ACEP is committed to. And so we are exploring different legislative regulatory ways that we can address this. Could we meet with CMS and see if this could be a condition of participation for Medicare, for instance? I think there's a number of ways that we are looking into how we best promote this. But fundamentally, I believe in this, our college believes in this, and we think this is vitally important to have due process for all emergency physicians.
And from my standpoint as a policy guy, this is something where, you in your position as president get to go and have these conversations with the lawmakers, and that's great. But I think it's also really important that we have members, constituents all over the country able to talk to their individual members of Congress, because if you're saying there is a bill that we're able to promote from Rep. Ruiz, who is an emergency physician, then we're going to need members everywhere to be able to talk about it.
Absolutely. I think grassroots advocacy is the most impactful way to change the law, to really make those things we want to happen come into play. And this is where, your voices are so needed, is to help elevate that message. They're not just hearing it from me, but they're hearing from all 40,000, ACEP members in the larger community. This is something that we feel is incredibly important. And I think, if anything, the pandemic has helped raise that awareness that there are safety concerns that people should feel safe speaking out about. And this is something that we need to protect and fight for.
All right. There's also this physician surplus on the horizon. If you haven't opened up Annals of Emergency Medicine recently, you definitely need to look at the workforce report. Many more physicians expected to be produced over the next 10 years than are needed to work in our emergency departments. And this has a lot of our younger members, especially EMRA members, really concerned. So how do you plan to address their concerns this year?
So absolutely, this is something that people understandably had a lot of panic about, and job security and what is the future going to look like. I applaud ACEP and the others within our work group of studying this back in 2017. Many people thought we were crazy for doing this, that it was a waste of time and money because we would never have enough emergency physicians. So I applaud that foresight of realizing that the market is changing, that there are other people now practicing in the emergency department. Our residencies are growing at a faster rate than they had historically. What is this going to look like? So I think that bought us some time to really appropriately navigate and address these issues head on. And we're not the first one to have a surplus. We won't be the last. But by definition, whenever you do a workforce projection, the minute you publish it, it's already changing the impact of that future, because you've kind of put into process that now people are aware that it is an issue and they make different decisions based on that data. So a couple weeks ago, ARIS came out with their data, and for the first time, we have a decrease in the number of medical students compared to last year who are going into emergency medicine. And that is predictable, that markets are, responding predictably. That is a good thing, that we understand that this is still the best specialty to go into, but we have to really promote it to people who really want to do this. And if there are people considering different fields, we need to make them aware of the realities of what the future looks like. But we are addressing it essentially by looking at 5 different pillars that address both the supply and the demand. So on the supply side, we're looking at how do we raise the standards to really look at accreditation for the future and best prepare our residents for the workforce needs in 2030. You can't put a moratorium on new residency programs because of antitrust issues, but we can raise the bar to really look at procedures and scholarly activity and facility and faculty requirements to make sure that we're offering the highest quality for our residents of the future. We can meet with people who have started residency programs, and we've had some very interesting discussions with hospital systems like HCA, the largest for-profit hospital system in the country, who has not only been shy about it, they've been actively promoting that this is their mission, is to build GME, that weren't really previously aware of our workforce data, for us to put pressure on those systems to say, stop that. This is not the time to be exploding emergency medicine residencies. And then on the flip side, we're looking at demand. So how do we address the distribution problem we have right now, where much of rural America doesn't have enough emergency physicians? How do we look at loan repayment options? How do we incentivize physicians to feel comfortable in different kind of areas to practice in? And how do we expand our skill set to look at what we can do outside of the 4 walls of a hospital, be it telemedicine, post-acute care, new hybrid or freestanding delivery models? I've seen a lot of really exciting ways to practice, that people are now proceduralists or running critical care and ICUs. So I think this is just part of our evolution as a specialty, and it's an opportunity to really change who we are becoming and what we can be in the future. So my message would be one of hope and optimism, that yes, there's going to be some challenges and there's going to be some short-term things that we're going to need to struggle through together, but we're going to get through this and we're going to have a better future because of it.
Right. Well, a lot of what you talked about today is a focus on what ACEP is doing for physicians, and very physician-centric. And I think that's great. But what about our patients and our community? How does that fit into ACEP's vision as well?
So I think as we sort of pivot from advocating for not just the specialty, but in particular for the emergency physician, it's that we're not losing focus of the patient. Everything we do is about the patient. But oftentimes, when you get on an airplane, and I travel with my kids, the flight attendant, the first thing they tell me is, in the event of an emergency, put your own oxygen mask on first. And I think that's what we're doing, is we're realizing that if we don't take care of each other first and foremost, we're not going to be able to provide that effective patient care. If we're burnt out and we are exhausted and jaded and cynical, we're not going to be able to take proactive, really good care of our patients. And so I think it's still very much tied to everything that we do. And many of our resolutions this year were on everything from mental health to opioids to very patient-centric advocacy efforts. But at the core of that is protecting the emergency physician to be able to deliver that care.
Right, excellent. Well, I've asked you a lot of questions, and thank you for taking the time to sit with me. What do you think is the most important thing that I didn't get to ask you?
I would say the most difficult thing is, what's next? How do you inspire hope in a time where people are very demoralized? I think this is one of the more challenging times for emergency medicine as a specialty. I think every ACEP president probably feels that they're inheriting the most difficult problems, but I certainly feel that way right now with so many challenges in our future. But I do want to give a hope and optimism that knowing that this is who we are and what we do. When we come into a shift, we don't know what's coming in. Half the time, we may not have the right equipment, or the EMR goes down and we're scrambling for paper T-sheets, or the nurse called in sick. This is the reality of our practice, is that we MacGyver and we adapt around unforeseen challenges, and we thrive on the ability to do that and to provide excellent care despite those challenges. So I see this as a challenge. It's going to be some ways that we're going to have to constructively work together. But in that message of unity, it's that if there was ever a time for us to come together, to rally behind one another, it's right now. We need everyone's support and common efforts to realize that we're not always going to agree on everything, but where can we find that common ground to help support one another, to advocate for our patients and for our specialty and for each other. And I'm very optimistic that we're going to get there.
All right, well, thank you so much. We're going to have a quick little lightning round. Why should every ER doc be an ACEP member?
Because it does the most for the emergency physician. We advocate for you more than anybody else.
All right. What is your favorite ACEP convention city?
Ooh, I have to go San Diego.
Okay. This one might be get you into trouble a little bit. Who's your favorite past president of ACEP?
I'd have to say Paul Keevala.
Okay. What's next for you after this?
Good question. I am excited to have a little bit more time to spend with teaching. I really value working with my medical students and my residents, and I'm looking forward to being able to advocate a little bit more time in that arena.
All right. Well, Dr. Gillian Schmitz, ACEP president for the upcoming year, thank you so much for joining me today on ACEP Nowcast. And I hope to sit down with you maybe in about 6 months, see where we are, see where the issues are, and see how emergency medicine is doing in this country.
Wonderful. Thank you so much for your time today, Cedric.
Thank you.